Assalamu alaikum, Dr. Ashir Mahmood here. In this video, we are going to learn about the asthma, the practical aspect of management of asthma. The important thing in this lecture will be that how you are going to diagnose a patient as asthma, how will you differentiate a wheezy child that is not asthmatic, just wheezy because of viral infections or because of bronchiolitis or because of the other reasons, and which child is asthmatic, and how you are going to start treatment, how you are going to monitor treatment, and how will you escalate treatment or step down treatment, and what treatment are to be given and in which way. So we will discuss practical aspect of asthma management in this lecture. So asthma, as per definition, is basically a chronic condition of respiratory tract, is an inflammatory condition, is allergic condition, which is characterized by the recurrent episodes of episodic bronchospasm. And this is because of the hyperresponsive of the of the airway. This hyperresponsiveness of the airway can be due to the different stimuli that can be dust, smoke, pollen, mites, and other things. So asthma is a reversible bronchospasm due to it is chronic inflammatory condition of the airway, and it is due to the hyperresponsiveness of the airways. So the definition you should know the asthma. Now, the important characteristic of asthma is the wheeze. The wheeze is basically a sound that is produced by the nerving of the the lower airway in the form of at the level of the bronchioles and the bronchioles. So the wheeze is characteristic of asthma. So every child is a wheezy child is asthmatic. It is very important question. No, every wheezy child is not asthmatic. So we divide the children into two age groups. One is the less than 5 year age, and other is the more than 5 year age group. In more than 5 year age group, it is easy to label the patient as asthma. The reason being is that patient has passed the time of 5 years. In 5 year time period, the course of history is defined. You will, when you take history, you will check whether the patient has history of atopy, patient has history of repeated episode of the bronchospasm, patient has the history of repeated episode of wheeze that are responsive to the bronchodilators in the form of nebulization. So it will be easy for you to label a patient as asthmatic after the age of 5 years. And there are other causes of the wheeze that are typical in less than 5 year age, that are very rare above the 5 year age. So above 5 year age, it is easy for you to label a child asthmatic. Below 5 year age, it is difficult. The reason again is that you don't have a sufficient time for the history of disease. There are other various causes that are very common in this age group rather than asthma for the wheeze. So we will discuss that. So wheeze in children age under the 5 year of age is old is very common, and it doesn't always mean that your child is having asthma. The cause of wheeze in children depends on the child's age, the other symptoms, and the risk factor. So the wheeze is not always asthma, it depends upon the other things also. So most common cause of wheeze in the first year of life and even up to the age of 2 years is the bronchiolitis. Bronchiolitis is a viral infection. It is most commonly caused by the respiratory syncytial virus, and it causes nerving of the lower airway and produces a wheeze. So in first year, most common, until the 2 year, it is a top cause of wheeze. So you have to look for it. Second is the viral upper respiratory tract infections or viral induced wheeze. This is the most common cause of wheeze in children age 1 to 4 years, and it happens when your child has some cold or chest infection. Your child is usually well between the infections. So in between infection, child will be well. Whenever child will get some infection, he will be wheezy. So this is the viral induced wheeze, and it is common in 1 to 4 year of age group. There are various other causes of wheeze that come in the differential of the wheeze that should also be looked in this age group, especially that include rhinosinusitis, that include gastroesophageal reflux, that can be due to the tracheobronchomalacia. Some other causes, rare causes, are that like vocal cord dysfunction that can also lead to the wheeze. Similarly, the parasitic infection in the form of Loeffler pneumonia. Similarly, the hypersensitive pneumonitis. So these all also can cause the wheeze. So these are also come in the differential of the wheeze in the age group of less than 5 year of age. About half of all the children with the wheeze will grow out of their symptom by the time they start school. So half of the wheezy children will grow out of wheeze as they go to school. In preschool, asthma is basically can be the cause of wheeze in children, especially if there is a family history of asthma allergies. Is then it can be so the asthma can start. It doesn't mean always that the wheeze below 5 years is not asthmatic. The asthma patient can have a start of wheeze below the 5 year of age, so it also come in your differential. So what are the characteristics that make the wheezy child more likely of asthma? So these are at night, or when patient is having wheeze or cough that is more pronounced at night, or when they wake up. During and after the exercise, if wheeze is more pronounced or cough is more pronounced, then it is a favoring point for asthma. When there is a trigger, when the cough or wheeze is trigger based, like cold weather, dust, pollen, smoke, grass, or certain foods, then it is likely that patient is allergic and atopic. When the child is otherwise well, only having cough or wheeze, that is favoring point for the asthma. So asthma is more likely if your child has having eczema or allergies or family history of asthma allergy. This is very important point, that personal history of atopy and family history of atopy is also a very favoring point that patient is asthmatic. So these are various triggers that have been shown in this video in the form of pets, stress, anger, pollution, strong odors, smoke, dust, fungus, cold air, chemical fumes, bugs in the home, pollen, and exercise. So if patient is having triggered by these factors and reversible bronchospasm, repeated episode, personal history of atopy, family history of atopy, eczema, food allergies, so all these points are favoring the patient is having asthmatic. So as per Nelson, approximately 80% of all asthmatic patients report disease onset prior to the 6th year of age. So 80% will have a disease onset prior to 6 years of age. However, of all young children who experience recurrent wheezing, only a minority will go to have persistent asthma in later childhood. So minority will be go to develop asthma. Early childhood risk factor for the persistent asthma have been identified and have been described. That are parent asthma, if patient is having parents that are asthmatic, if patient is having eczema, if patient is having inhalant allergy sensitization. So patient is sensitive to various factors that I have described earlier. And there are other minor factors like patient is having allergic rhinitis, patient is having wheeze apart from the cold, and more than 4% peripheral blood eosinophilia. So CBC will show peripheral eosinophilia and fluid allergen sensitization risk factor. So allergy in young children with recurrent cough or wheeze is strong identifiable factor for persistent of childhood asthma. So when you are going to evaluate a childhood asthma, you will take the history of the parent, whether they are asthmatic. You will check patient for the eczema, for other allergic sensitization, and you will do his CBC for eosinophilia, history of allergic rhinitis, and wheeze from other than the cold. So if these factors are present, then more likely make the child to have asthma. History is very important, that asking about previous experience with asthma medication, that bronchodilator may provide a history of symptomatic improvement with treatment that supports the diagnosis of asthma. So if you take history, you say that parents say that patient gets recurrent wheezy, and patient when gets nebulized, there is rapid improvement, there is rapid response. This is also a favoring factor that patient is asthmatic. So lack of improvement with the bronchodilator and corticosteroid therapy is consistent with underlying asthma, and lack of improvement with bronchodilator and corticosteroid therapy is inconsistent with underlying asthma and should prompt more vigorous consideration of asthma conditions. So if there is no response to bronchodilator, there is no response to steroids, and patient is wheezy, it is not asthma. Look for other causes. The presence of risk factors such as history of other allergic conditions, allergic rhinitis, allergic conjunctivitis, atopic dermatitis, food allergies, and also the parental asthma and symptoms apart from the cold support the diagnosis of asthma. So all these factors if present, they support that patient is asthmatic. In clinic, quick resolution within 10 minutes or convincing improvement in symptoms and signs of asthma with administration of inhalant short-acting beta agonist, that is Sabas albuterol, is supportive of diagnosis of asthma. So if child comes to your clinic with wheezy chest and you give him bronchodilator therapy in the form of albuterol, salbutamol nebulization, and there is rapid response, patient is likely of asthma. So once you diagnose asthma, and then you will proceed next. So this is the flow, and this is basically the pattern of management of this asthma. So first we will do assessment, that how patient is going on, what is the severity classification of patient, and then we will monitoring. So assessment is done by the severity classification and monitoring is done by the control classification. So these two classifications you should remember if you want to treat a patient with asthma: severity classification as well as the monitoring classification. Next is that before start of treatment, education is very important. People are fear of the inhalers, people are fear of the disease, people are fear of the chronicity of the disease. So you should educate them about that. Also the home environment should be changed for the patient, that the setting should be made that are supportive for the patient. So education is important. Second is the control environment factor and comorbidity conditions. So environmental factor and comorbid conditions should be controlled. Then we will start the medications and we will manage the exacerbation. So first is that we will classify the patient as per severity. We will educate the patient, we will control the environment of patient and make him less allergic, and then we will monitor the patient as per the severity classification, and we will continue monitoring the growth of child, and we will prevent and manage the exacerbation. So these are the aims of treatment of asthma. So education, as I have already told you, that in education we will educate the patient about disease, about the nature of illness, about its course, about its repeated episodes, and how we are going to manage at home, what are the conditions which make the child to go to emergency, and we will teach them how to use the drug delivery system, that can be nebulizer to inhaler to DPI. So all education is very important, and we will make their fear of the inhaler, especially in our uneducated society, that if inhaler are being taken as a sign of fear, that they will be for the child for the whole of life. So that's very important. Control of environment is very important, that I have already told you that there are various risk factors that trigger the asthma. So try to control them. Likewise, if the second-hand smoke should be avoided at home, the second-hand smoke should be avoided, very important, strictly at the home if patient child is having asthma. Proper cleaning of home is important. Dust when dusting is done, the child should not be in that room. The carpet should be removed from that room, and try to have the air conditioning system in that room. There should be plastic sheets and covering the beds and the pillows. Similarly, if there are pets, that should be also removed. Molds, all things should be removed. Strong odors, and from the before exercise, salbutamol therapy should be given. Cold air should be avoided. So all the triggers that trigger the asthma, more likely in that child, they should be avoided and they should be removed, and try to make the environment as comfortable as healthy for that children. So environmental changes are very important. If you are going to start treatment without changing environment, the treatment will not respond. So environmental changes are the first step in management of asthma. These are very triggers shown in this picture in the form of pets, fungus, sponge, pollen, smoke, pollution, anger, strong odor, dust, cold air, bugs, and exercise and stress. So these should be managed, as I have told. So then next step is that severity classification. You are going to classify the asthma, that in which category the asthma in this child is falling. So intrinsic disease severity while not taking the asthma medication. So severity classification is done at the start of treatment when the patient is not taking any asthma medication. So it can be intermittent or persistent. When persistent, it can be mild, moderate, or severe. So once you start treatment, then you will go for the control classification. So control classification is for the patient who is on treatment. Clinical assessment is while asthma being managed and treated. So you will go for control classification. Control classification is well controlled, not well controlled, and very poorly controlled. So important point is that if patient comes with who is not on treatment, then you will classify him as per severe classification. If patient is already on treatment, then you will classify him as per the control classification, and you will move onward and onward. The National Asthma Education and Prevention Program recommends a stepped approach to asthma treatment based on the age and asthma severity. So step treatment is that depending on the severity classification and control classification, you will move the treatment up or down. You will add up treatment, or you will step back and remove the drugs. So it is a very dynamic system that it is not fixed drugs for asthma, but it increases with the increasing severity of disease and decreases with decreasing the severity of the disease. So stepwise, as per age, less than 4 years and above 4 years, but I have shown a single part for the convenience. There are not a lot of difference between them, so we will follow it. So step 1 is the SABA as required. SABA is the salbutamol nebulization. Step 2 is the low dose inhaled corticosteroids, or you can also give the cromolyn or montelukast at this step instead of it. Step 3 is the medium dose inhaled corticosteroids. Step 4 is the SABA will continue. So as you move upward, the previous step will continue. So SABA plus low dose. Step 2, SABA plus medium dose inhaled corticosteroids. Step 3, SABA plus medium dose inhaled corticosteroid plus either LABA, that is long acting beta antagonist, or LTRA, that is leukotriene receptor antagonist. So in step 4, you will give him SABA as required plus medium dose inhaled corticosteroid along with the LABA or LTRA. Step 5 is the high dose inhaled corticosteroid along with the LABA or LTRA. And step 6 is the high dose inhaled corticosteroid with LABA, LTRA, and oral corticosteroid. So in this, oral corticosteroid will be added. So SABA, medium low dose inhaled corticosteroid, medium dose inhaled corticosteroid, medium dose plus LABA, LTRA, high dose plus LABA, LTRA, then high dose plus LABA, LTRA, and oral corticosteroid. So these are the 6 steps of management. You should remember them. So what is the classification of asthma severity? So asthma severity, as I have already told, patient who is not on medication comes to you first time, you will classify as per the asthma severity classification. It can be intermittent, mild, or moderate, or severe. So it can be intermittent or persistent. In persistent, it can be mild, moderate, and severe. So the symptoms, the daytime symptoms are same for all the ages. If it is less than 2 days per week, then it is intermittent. If more than 2 days per week, it is persistent. In persistent, mild, moderate, or severe. If it is more than 2 days per week but daily patient is not having symptom, then it is mild. If patient is having daily symptoms, then it is moderate. And if patient is having symptoms throughout the day, means multiple time a day, then it is severe. So nighttime symptoms in age 0 to 4 year, and we divide it into age 0 to 4 year and more than 5 years. So intermittent in night time, in 0 to 4 years, there are no symptoms. In mild, 1 to 2 nights per month. In moderate, 3 to 4 nights per month. And in severe, more than 1 per week, but not every night. So 0 to 4 year, nighttime symptoms. In intermittent, no nighttime symptoms. In mild, 1 to 2 nights per month. In persistent, moderate asthma, 3 to 4 nights per month. And in severe asthma, more than 1 per week, but not daily. In more than 5 year age, the nighttime symptoms increases, as in intermittent there should be less than 2 episodes of a nighttime symptom per month. In mild, 3 to 4 per month, and in moderate, more than 1 per week, but not nightly. And in severe, often 7 into week. So every night you will get symptoms. So you should remember this classification of asthma severity. I will revise it that daytime symptoms are same for all ages. So if less than or equal to 2 days per week, it is intermittent. More than 2 days per week, but not daily, it is persistent, mild. In moderate, daily. In severe, throughout the day. Nighttime symptoms, as I have already told, that in case of age 0 to 4 year, in intermittent, no nighttime symptom. In mild, 1 to 2, moderate, 3 to 4. These are per month, and if more than 1 week, more than 1 night per week, then it is severe. And in age more than 5 years, uh, less than 2 days per week to less than 2 nights per month is intermittent, and in mild 3 to 4 nights per month, in moderate more than one per week but not every night, and in severe you will get symptom every night. So you should remember this all. So how you are going to start treatment after classifying the asthma severity? So in the intermittent asthma, you will go for step 1, that is SABA. In case of persistent asthma, that is mild, you will go for the step 2, that is low dose inhaled corticosteroid along with the SABA. In moderate persistent and severe persistent, in both you will go for the step 3, that is SABA plus medium dose inhaled corticosteroids along with the short case of oral corticosteroid. And oral corticosteroid are given in the form of delta cortical that is prednisolone, mostly for period of 3 to 10 days. So once you start that, we will give it for the period of 3 to 10 days. So once you start the treatment, you will evaluate the child meanwhile for the control, and the next you will call the child and you will see whether patient is being controlled, having control of disease or not. So it is very important to check for the control of disease. Now we'll discuss the control classification of the child. So control can be well controlled, not well controlled, and very poorly controlled. So these are 3 classification of the control. Again we will divide it into the symptoms that are daytime symptom and nighttime symptoms. So daytime symptoms, if less than 2 days per week, then it will be the well controlled. If these are more than 2 days per week, then it will be not well controlled, and if occurring throughout the day, then it is very poorly controlled symptoms. So less than 2 days per week, well controlled. More than 2 days per week or multiple times on less than 2 days per week, then it is not well controlled, and if symptoms are coming throughout the day, then it is very poorly controlled. Similarly, it is the nighttime symptoms for age less 0 to 4 year, age 5 to 11 year, and age more than 12 year. So if as these are shown here, you can memorize it from your book also. So as per them, you can classify the patient as well controlled, not well controlled, and very poorly controlled. So important point is that control classification is applied once child is on the treatment. So it is also in control classification, if 0 to 1 year, 0 to 1 year per year, if you get exacerbation which requires systemic steroid, then it is also a well controlled. Not well controlled is 2 to 3 per year, and more than 3 per year exacerbation are very poorly controlled. And for the age more than 5 years, if 0 to 1 per year, it is well controlled, and if it is more than 2 per year exacerbation of asthma requiring systemic steroid therapy, then it is not well controlled. So these also should be looked. So what you will do as per control classification, what you will take. So in well controlled, you will maintain the current step. Regular follow-up is done every 1 to 6 months to maintain the control, and consider step down if well controlled for at least 3 months of period. So once you got a patient who you label asthma, you started treatment in the form of step 1, 2, 3 or 4 as per the asthma severity classification. You followed that patient and you check the control. If patient is having well control, you will continue that step for period of 1 to 6 months, and you will continue that step. You will follow him every 1 to 6 months. So monthly follow-up in start, and then later you can call him 6 monthly. And after 3 months of period, you can step down the period. Suppose patient was on the step 3 in the form of medium dose inhaled corticosteroid. After 3 months, you can step down him to the low dose inhaled corticosteroid. And again, after step 3 months, you can step down the patient to the SABA as required. So this is the pattern. So if patient is having a second type of control classification, that is not well controlled, so in that case you will step up one step. Like patient is on step 2, then you will shift to step 3, and you will re-evaluate the patient in 2 to 6 weeks. If there is no clear benefit in 4 to 6 weeks, consider alternate diagnosis. are adjusting the therapy. So you will follow that child in a 2 to 6 week therapy, and you will look for the control again. If there is no improvement, you will look for either the alternate compliance. You will check for the compliance. You will check for the alternative diagnosis. You will check for adding the step or more step. If patient is very patient is falling in control classification, is very poorly controlled, then you what step you will take. So in this case, you will consider short course of oral corticosteroid. You will step up. Here you can take 2 step up. Patient was step 2, low dose in oral corticosteroid. You can directly jump to step 4, that is medium dose in oral corticosteroid along with the LABA or LTRA. So you will follow the patient after in 2 weeks. If there is no clear benefit, again you will check for compliance, you will check for alternative diagnosis, and you will check for the adding up therapy. So this is the protocol of asthma. First, diagnose asthma. Second, classify asthma as per the severity classification. Third is start treatment as per the severity classification. Fourth is that you will follow up and you will apply the control classification. And fifth is, as per control classification, you will monitor the child for the step up, step down, or keep on that step. So if one drug is not enough to control your asthma in 2 to 6 weeks, your treatment goes up 1 step. This may increase the dose or adding another drug. If asthma is well controlled for at least 3 months, you may go down 1 step. So if 3 months asthma is well controlled, you can go down 1 step. The dose of prednisolone, what dose prednisolone should be given. So it is as per the age 0 to 4 year, 5 to 11 year, more than 12 year. So prednisolone is given as a short course. In 0 to 4 year, it is given as 1 to 2 mg per kg per day. Maximum dose is 30 mg for the period of 3 to 10 days. For 5 to 11 years, it is given as 1 to 2 mg, that is usual dose, and maximum dose is 60 mg for 3 to 10 days. And more than 12 year, it is again given as a 4 to 60 mg per kg per day as a single dose or 2 divided doses for the period of 3 to 10 days. So 0 to 4 year, maximum dose is 30 mg, 5 to 11 year, maximum dose is 60 mg, and more than 12 year, we will directly go for the 40 mg per kg, 40 to 60 mg per kg per day as a single dose or double dose, that is given as a period for the 3 to 10 days. So nebulization, how you are going to medicate the child. So in asthma, we try to give the drugs that have local effect. So local effect, that they will only affect the bronchi, the airways, and they will not have systemic effects. So our target is that. For that, we use different type of drug delivery system. So these can start from the nebulizer through the inhaler in the form of inhaler, that can be a meter dose inhaler or disc powder or dry powder inhaler. So nebulizer with mask is recommended for children under the 3 years of age. So important question that is raises in our mind while managing asthma is that what should we prescribe? So at what age, what should be the treatment of choice? At what age, what device we should give to the child? So that when you were going to nebulize, advise the parents to nebulize your child with a nebulizer machine, or use asthma for asthma management with the help of meter dose inhaler, or when to use the spacer, when to use MDI with spacer, MDI with mask, or when to use the DPI, that is dry powder inhaler. So these are different ways in which drugs can be delivered to children. Nebulizer with mask is recommended for children under 3 years of age, because the coordination and reflexes are not well developed to use the inhaler. So under 3 years of children, you will go for the nebulizer. Treatment of asthma or wheezy child will be nebulizer. Under 3 year, nebulizer. MDI, meter dose inhaler with the holding chamber, spacer and mask for children less than 4 years of age. So less than 4 years of age, you can use the MDI, but you have to attach a mask with it and spacer device. MDI with holding chamber, spacer for children greater than 4 years of age. So after 4 years of age, you don't need the mask. You can use the meter dose inhaler along with the spacer device only. And dry powder inhalers, that are DPI, are children greater than 4 years of age and older. So more than 4 years of age, you can go for the DPI, that is dry powder inhaler. These are various devices. One is the nebulizer machine. It is having 2 ports. One is the exit port, in which the tubing is attached, and then a port is seen where the medicine and the nebulizer solution is added, and patient is being nebulized for a period of 5-10 minutes as per the dose of drug. So these are the various inhalers have been shown here. These are come in different color coding. The color coding also shows the which type of medication they are containing. As you can see, the bluish color is of the relievers and the preventer are of brown color. So important is that you can identify the inhaler just by using color. These are the DPI devices that are dry powder inhalers. So how you are going to use the these MDI inhalers along with spacer. So the mechanism and the method is shown in this video. So first step is that you will shake the inhaler. Second step is that you will attach this inhaler to the spacer device. Third step is that you will firmly press the lips around the first you will exhale and then firmly press the lips around the mouthpiece of the spacer device. Then next step is that you will press down the inhaler, and then you will slowly after pressing down you will take slowly deep breath in, and then you will keep the breath inside for the period of about 10 seconds, and then you will exhale. So if patient is using a steroid based drug, then he should also rinse after the period after this inhalation, because can cause the candida infection of the oral cavity as well as the vocal cord myopathy. This picture is showing how to use the DPI, that is dry porcelain inhaler. So first step is that you will do the cleaning. Second step is that you will charge the open the DPI device. Third step is that you will charge the drug, and sixth step is you can sit stand, you can do it. Seventh step is that you will first exhale. Then next step is that you will firmly place the lips around the delivery site, and then you will inhale it, and you will keep inhaling for the period of 10 minutes, and then you will close the drug. This is showing, the picture is showing how to use inhaler. Again, first shake the inhaler. Second is that you will exhale, and third step next step is that you will inhale it, and then you will keep it for the period of 10 seconds, and then you will exhale it. And if you have taken steroids, then you will rinse your mouth. Now spacer needs cleaning, so spacer should be cleaned once a week. Take the spacer apart. So parts of spacer are taken apart because they are removable, and wash it with a warm water containing a little dishwater detergent or mild soap. Do not rinse the spacer. It is important to leave the residual soap on the inside lining spacer to minimize the static electricity space. So this is where we wash the spacer device. So once in weekly washing is important. So now we will discuss that which drugs are available in Pakistan and how we are going to give them as per the protocol. So this is very important. So SABA, that is short-acting beta agonist, that most commonly given in the form of the two drugs that are Ventolin available in the form of Ventolin inhaler and Salbo inhaler. So Ventolin inhaler comes as 100 microgram per action. So per puff you will deliver the 100 microgram. And in case of Salbo, that is also a salbutamol inhaler, also giving us 100 microgram per puff. So these are both our drugs are Salbo. So the step 1 drugs are SABA, that is salbutamol, and these are given as a Salbo inhaler or Ventolin inhaler. So dose of these is that you will give 1 to 2 puff as required. So whenever patient gets symptom wheeze or chest tightness, he can give 1 to 2 puffs. And the maximum dose of that is the 8 puffs per day. So 8 puffs is the maximum dose, and usual dose is 1 to 2 puff. And whenever patient requires, like patient is having chest tightness, patient is having wheeziness, you can give him this. Next step in our drugs comes the leukotriene receptor antagonist, that is montelukast, that is most commonly used as the next step. So the Monteca usually comes in the form of 4 mg tablet, 5 mg tablet, and 10 mg tablet, and 4 mg granules. The granules can easy to administer in younger children because they can be taken along with the 1 teaspoon of the food particle. So if child is 1 to 5 years, the dose is 4 mg. If age is 6 to 14 years, the dose is 5 mg. And if age is more than equal to or 15 years, then dose is 10 mg. It is taken usually at the bedtime. So second step is the montelukast. These are various is come in the form of Monteca, Montegard, Montica 4 mg tablet, chewable tablets, Montica 4 mg, 5 mg tablet, 10 mg tablet, and the 4 mg the granule sachet. So the next step in is the our treatment is the steroids. So steroid is most commonly uses the fluticasone in the form of flixotide inhaler, and it comes in the form of 50 microgram per action, 125 microgram per action, and the 250 microgram per action. So if you can give him a 50 microgram per action inhaler BD, then it is medium low dose. If you give him 125 mcg inhaler BD, then it will be the medium dose. And if you give him the 250 mg auction per twice a daily, then it will be the high dose inhaler. So medium dose will be the 50 mcg BD, 125 mcg BD will be the, so low dose will be 50 mcg BD, medium dose will be 125 mcg BD, and the high dose will be 250 mcg BD, the dose. So flixotide fluticasone inhaler comes in the three forms: 50, 125, and 250. 50 BD is the low dose, 125 BD is the medium dose, and 250 BD is the high dose. So in step up, as you know that in step 2 you will give him the low dose, in step 3 you will give him the medium dose, and in step 5 you will give him the high dose. So this can be given. Now LABA, the most commonly LABA available is the salmeterol. It comes as a servant evohaler, and it is 25 mcg per action. So one puff will give 25 mcg. The dose is 1 puff BD. The dose is 1 puff BD. So you can add it in the to the medium dose or high dose steroids in step up therapy. So it will be servant inhaler and 1 puff BD dose, fixed dose. Then combination of steroid and the and the LABA. So you, as you know that if you go step up from the step 4, 5, or 6, you have the combination of the steroid along with the LABA, because both of these will be used at that step. So in this combination, most commonly available combination is the salmeterol along with the fluticasone. So it come in the name of salmicort or seretide evohaler. The salmicort seretide evohaler, in both of these the dose of salmeterol is fixed, that is 25 mg BD. However, the dose of fluticasone is changed from the fluticasone will be in the 3 doses, that is 50, 125, and 250. I have already told you that in the medium dose it is 50 BD puff. In low dose it is 50 mcg inhaler BD. In medium dose it is 125 mcg inhaler BD, and in high dose it is 250 mcg the BD. So you will select as per the severity classification of the child that which inhaler and what dose and how many puffs are to be given. Now important is that the nebulizer solutions, there are different nebulizer solution available, and their dose is also very confusing. So these 3 are very important. They include the atom, clanal, and Ventolin solution. So Ventolin solution comes in the form of 5 mg per ml. So 1 ml contains 5 mg. There are almost 36 drops in 1 ml, and dose is 1.1 mg per kg. 0.1 mg per kg is the dose, and maximum dose is 1 mg, that is 1 ml, that is 5 mg, and it is adult dose. So usually we give the dose as per the weight, that if patient is having 8 kg weight, roughly the dose will be of 6 to 7 drops. Similarly, the maximum dose is the 30 drops, that is adult dose. In case of atom usually we give the children 3 year and onward, and the atom ampule comes in the form of 2 mcg. It is 2 ml ampule, and we give him the half ampule, and it is given thrice a day. And similarly the clanal ampule, it is given as half ampule, a fixed dose, and it is also given 3 to 4 times a day as required. So this was a brief review of the drugs and management plan of asthma. So let's revise it, that how you are going to manage asthma case. First thing is that you will label the patient as asthma. For that you will check for the personal history, family history, atopy, response to drugs, and all these factors that we have discussed. So first you have to label a patient, whether patient is asthmatic or not asthmatic. Second step is the counseling of patient about asthma, that what is asthma and how will you manage, and what will be the factors which provoke the asthma, how will you manage exacerbation, and all other things that the concerns of patient. Third step is the environmental changes, that you will change the environment of patient. You will make the environment healthy for the patient, and you will remove all the triggers that are triggering the asthma in that patient. Fourth step is the severity classification. You will classify the patient as per severity. That patient is in intermittent or persistent state. In persistent, patient is mild, moderate, or severe. Next step is the start of treatment as per the severity classification. If it is intermittent, though step 1, it is mild, moderate, or severe, then you will go for the step 2 or step 3 with steroids. Next step will be that you will make the patient to come on follow-up, and you will classify as per the control classification. So you will control classification do that patient is having well controlled, not well controlled, or poorly controlled, and then you will adjust the treatment as per the control classification into step up and step down, and you will follow the patient. I have discussed the treatment option that in the step 1, SABA, that comes in the form of salbutamol, or Salvo. In step 2, mostly we use the Montica or Montigat in the form of 4 mg, 5 mg, or 10 mg tablet as per the age. If age is less than 4 years, then 4 mg, 5 to 14 years, then 5 mg, and 15 or onward, it is 10 mg. Now in step 2, 3, and 4 and onward, steroid are used. Steroids come in combination along with andalaba or separately. Separately they come in the form of Flexutide, that comes in the form of 50 mcg per action per puff, or 125 mcg per puff, or 250 mcg per puff. So 50 per puff, 50 per mcg inhaler BD is the medium dose, 125 mcg inhaler in the BD is the medium dose, 50 mcg BD is the low dose, 125 mcg BD is the medium dose, and 250 mcg BD is the higher dose. And in combination, the LABA, that come in the form of salmeterol, and it comes in the form of inhaler strength of 25 mcg, and it is usually given in the form of BD, so that is a fixed dose. And in combination also come in the form of LABA and the steroid in the form of fluticasone. So these come in the form of 50-25, 125-25, and 250-25. So these can be given in the BD form, depending upon the severity of classification, which severity of classification patient is following. And for the children less than 3 years of age, you have to go for the nebulization. Nebulizer available are the atom, clanal, and ventolin solution that can be used. Thank you.